Hello, my name is Jose Rubio, and I am Assistant Professor of Psychiatry at the Zucker School of Medicine at Northwell in New York. The aim of this study was to understand the circumstances under which prescribers use LAIs, particularly for individuals that are at the early phases of psychosis. And the importance of doing this is that LAIs are very powerful relapse prevention tools, and the first episode or the early phase of psychosis is when individuals have the most to lose from having a relapse. That's why we think it's the population that would benefit the most from using LAIs, but to date, we did not really understand how often they were used and under what circumstances were LAIs used for this patient population. What we did was to try first to find a data set that could answer this question, and it's not easy, but there's a data set that's called the IBM Market Scan commercial and Medicare supplemental databases, which do contain information about the prescription of long-acting injectables in commercially insured populations. So what we did was, once we had identified the data set that we wanted to work with, identify the patients that would be adjusting to our definition of early phase psychosis, and then we followed them up over time to look at how long did it take for these individuals with the first diagnosis of schizophrenia to have a long-acting injectable prescribed to them. I would highlight two main findings. The first finding has to do with the percentage use of long-acting injectables in this population of first episode psychosis. We found a utilization rate of about 10%, and that is actually much below the rate that we have from other data sets that are based on Medicaid insured populations, which tends to be around the 20%. So the first finding, I think it's the first relevant finding, is that this population has a percentage use of LAIs that's lower than the general population. The second finding that I think was relevant was the fact that LAIs are used in this population usually after things have gone south. For instance, after people have been on multiple medications that didn't really work, when people have discontinued most often medications, when they have already a history of hospitalization, etc. So what that tells us is that LAIs are most often used as reactive tools to someone having already been non-adherent and experienced relapse, as opposed to being a proactive tool that doctors use to prevent relapses. In my opinion, we should use LAIs whenever possible. There are very few circumstances under which you would prefer to use an oral to an LAI. I think that those could be whenever someone is treatment resistant. Obviously, the only drug that's approved for treatment resistance is clozapine, and that doesn't come in a long-acting. So that's obviously a very well-justified reason to not use a long-acting injectable. There are some situations, such as like when people cannot tolerate the drugs that come as long-acting formulations. So that would be olanzapine, paliperidone, risperidone, and aripiprazole. So, some people cannot tolerate those drugs, and then they have to be treated with other drugs that just come with an oral formulation. But I think that those are relatively rare. Most often, there's really not a reason to not use an LAI. In terms of side effects and safety, they are comparable to oral drugs. The worst thing that can happen to someone taking antipsychotics is neuroleptic malignant syndrome, which can be potentially lethal. But based on the data that we have, the outcome is really not worse for those who are taking long-acting injectables. So there are really not any safety reasons that would be compelling enough to not take advantage of the benefits of LAIs in terms of relapse prevention.